The University of Chicago transplant program is really built on a foundation of collaboration and multidisciplinary effort. We work very closely with our medical and surgical teams, and we use the advice actively of our immunology lab so that we have the best outcomes for our patients, and we can choose the medications selectively, and we understand that one size does not fit all.
We understand that each patient is unique, and we treat patient samples as well as donor samples with state-of-the-art technology, and we personalize evaluation of the test results.
We are always making sure that we're using the most cutting-edge technology to make sure that we're getting the best results for our patients. This can be things like using next-generation sequencing technology, which we're going to be introducing soon here into the lab, to refining the assays that we've been using for years and years. And all this is getting back to making sure that we have the best results for any patient or donor that we're testing.
So our electronic document management system has allowed us to be available to all of our surgeons and physician groups at all times throughout the day and night, both at home, from our office. Also, when we're in meetings actually with the physicians, we can answer questions for results that may not have been reported out yet because we have access to all that information in real time.
We are very proud to have an excellent one-year survival. It's reaching 93% success rate now in University of Chicago. That is above the national average. Side by side with that, we increase also our survival rates in mechanical circulatory support patient. Our outcome in 1 year mechanical circulatory support reached almost 84%, again above the national average.
Patient care is enhanced by the very close collaboration of the immunologic lab as well as the clinicians, so that our immunologists can explain to the clinicians what the antibodies mean, what the typing means, what the specific subtyping means. Because as clinicians, we know that the end point of a match is whether or not the kidney will or won't reject, or the organs will or won't reject. However, sometimes the very subtle subtyping, we may be perhaps able to choose medications so that we aren't at risk of rejection, and that's where we involve our immunologists to help us interpret a vast volume of data now that is available to us that sometimes as clinicians we don't quite know how to best interpret that, and they are instrumental in helping us figure this out.
We're currently in the process of implementing next-generation sequencing that is a high-throughput sequencing technology that could bring significant advantages in clinical testing, because we will eliminate HLA typing ambiguities that is present in the old molecular method of testing. In the future, this methodology has the potential for non-invasive monitoring of allograft rejection.
So recently we had a patient who seemingly had a lot of antibody, and we were able to provide some additional information by doing surrogate cross-matches against donors that were not necessarily linked directly to that recipient, and it allowed us to reduce the amount of antibodies that we listed in the UNOS system, and that actually got the patient transplanted much sooner.
So one of the reasons I really like working in a paperless lab here is it makes it very easy to find results for a patient. For example, if I'm called in the middle of the night by one of the transplant programs and they're wondering if they should accept a donor or not, I can take a look through our electronic record system and determine very quickly what the historical results have been, what the most recent results have been, and really give them a very accurate picture of the risk that would be for this particular patient.
We are very proud to do not only routine heart transplantation, rather than to take it to the high-risk patient population. Both high-risk patient population from heart transplant alone perspective, as HIV patient, that we are the only transplant center in Illinois that transplant HIV positive patients, and other high-risk morbidities and that can jeopardize or make the transplant more cumbersome. However, we are also very aggressive in doing multi-organ transplant. Last year, the University of Chicago Medicine Transplant Program done 7 heart transplants that were combined with other organs. 3 of them combined with liver, 4 of them combined with kidney. We were also the first transplant program that ever performed a combined heart, liver, kidney transplant in all one patient. So the heart transplant program of University of Chicago is really put as the flag outcome, side by side quality, without saying no to people that challenge our ability.